Welcome to the What About Rural Health podcast, a place where research, policy, and real-life stories come together to ask the critical question: what about the communities too often left behind? I am Chinasa, a development and global health policy strategist, and for me, this work is personal. From the village health workers struggling with limited supplies to the mothers walking miles for care, their stories shape the policies we need. Join me as we uncover challenges, spotlight innovations, and amplify the voices of those at the heart of rural health systems. Because every community matters, and it is time the world listens. Hello and welcome. You are listening to the podcast that asks the questions many forget. What about rural health? I am your host, Chinasa Imo, and together we are uncovering the stories, challenges, and innovations shaping healthcare in overlooked communities. Today's episode brings you a raw first-hand account from someone who has lived and led at the very front lines of healthcare in rural communities, during public health emergencies, and in the ongoing fight for better health systems. We will explore how this experience shaped the push for more just, prepared, and responsive health systems. In this conversation, we will talk about what it means to practice healthcare in rural and underserved resource settings, especially in the midst of crisis, the emotional toll, the leadership lessons, and the frameworks that is needed to support those who keep our health system standing, often against all odds. His journey reminds us why a resilient, protected, and well-supported health workforce is non-negotiable for achieving rural health equity. So if you are ever wondering, what is it like to stand at the intersection of crisis response, rural healthcare, and public policy advocacy? This episode is for you. Okay, so before we dive in, let me introduce you to our guest. He's someone whose work I deeply admire and whose leadership I have witnessed up close. Peterson Wachira is a clinical officer and infectious disease expert with a strong track record in health leadership, frontline response, and policy advocacy. He currently serves as the National Chairperson of the Kenya's Union of Clinical Officers. The abbreviation is called KUCO. And he's also the chairperson of the Health Caucus in Kenya, where he champions the rights, well-beings, and better working conditions for health workers and pushes for systemic and policy reforms across Kenya health sector. Peterson is a decorated recipient of the Kenyan Head of State Commendation, HSC, for his tireless advocacy, technical expertise, and commitment to elevating the role of clinical officers while strengthening health system resilience across Africa. And you would get to know why he deserves this award when we push this conversation forward. He also serves as a member of the think tank team of the International Association of Physician Assistant Educators and as co-chairperson of the Kenyan Health Workers Annual Convention. But beyond leadership and policy, Peterson is no stranger to the frontline response. He led the Kenyan contingent during the African Union mission to support the Ebola outbreak response in West Africa. And that is where our path crossed in Sierra Leone during the devastating 2014-2015 Ebola crisis. I serve as a humanitarian affairs and psychosocial officer with the Nigerian volunteer team, and Peterson led the Kenyan team. It was a moment of immense loss, shared sacrifices, resilience, and deep learning. But it was also one that showed the power of solidarity and Africa-led response. And since then, I have followed Peterson's work closely, and I continue to be impressed by how he uses his voice and platform to advocate for responsive health workforce policies that center care, not just for patients, but for those delivering it. That is what today's conversation is about. how critical it is to care for those who care for us, because a healthy population starts with a healthy workforce. So, Peterson, I'm so happy to have you join us today. Welcome to What About Rural Health podcast.
Thank you, Chinas. I'm very grateful for the invite.
Thank you so much for honoring the invitation as well. So, Peterson, I know your hands are full. You are a very busy person with so much on your plate. But before we get into the heart of our discussions, I would like to know, and I bet our audience would also love to know, what are you currently working on, and why has this work been so important to you, personally and professionally, especially in your role as a clinical officer? Is there a personal story to this?
Yeah, thank you, Chinas. And that's a very important question. And I really like your podcasts. What about rural health? Because most of the times, we really do not talk about the primary health care and the community health, which basically looks at the quality of the health care and the primary health care and the community health. And when I was growing up, I really admired. I used to see some nurses and clinic officers in the rural areas. And these are the people who used to come through the school health program, and they would give us some health education. They would advise us. They would sometimes give us dewormers and other preventive drugs, sometimes vaccines. And that is when I think I thought that probably this is a very good thing, because I can see that they're making a lot of impact in the rural areas, where by then we were not developed enough to afford those hospitals. And by then we didn't even have a social health insurance in Kenya. So seeking medical attention was quite expensive. And so from that time, when I was a young boy, I think I had already decided that I actually want to go into the medical field. I want to impact the society, but more of preventing, so that you don't have to go to the hospital in the first place. But then when I grew up and got into the medical field, I realized you can only do so much if you sit in that clinic, if you sit in that hospital and see patients. And that is when I thought maybe it would be better to be at a point where you can influence the policy, because now that goes beyond a patient sitting before you to impacting how a community then is affected by the interventions that are put in place to ensure that they have better health care. So that is my story, and that is my driving force. That is why I'm always out there trying to seek solutions that are going to make health better, and especially on the preventative promotive bits, which should be done at the community level.
Thank you so much. And when you were talking and sharing your personal experience, I think that if I ask 70 health workers, so 65 of them would definitely connect their story to their personal experience, either growing up, even myself. Like, so many people ask me, why are you hell-bent on advocating for healthcare accessibility? I'm like, I experienced that growing up, and I knew what it means when you are sick and you do not have a health facility to go to because you live in a marginal space. So thank you so much for sharing your personal story. It resonates with many of us. So, but I'm curious to know, like, at this time, what are you working on? Because I want to go into your head and see, what is Peterson working on right now?
Well, there are several things that we are trying to do, because I'm a staff at the Ministry of Health at the policy level in the headquarters. On the other side, I am a health advocate in terms of being a unionist and advocating for better policies, not only for the health workforce, but also 360 degrees, supporting all the pillars that make an effective health system, because of the understanding that there is no way you're going to better the working environment of a health worker without first ensuring that the patient can be able to receive better care. because a better environment for a healthcare worker means that they have the requisite tools and equipment and the essential supplies that they need to ensure that their patient is treated well and that the environment is also safe for them and the patient. So you cannot actually fight for a health worker without fighting for the patient. We have also realized that the level of clinical officers, and I think it's important for the audience to know, that clinical officers are not the medical doctors. Yeah, they are primary clinicians. Their work is similar to that of the doctors, except that they do not reach the extent the doctors reach to. And for example, the difference between a medical doctor in Kenya, who we call medical officers, and a clinical officer, a clinical officer can basically do what a medical officer can do. But now when it comes to the surgical procedures, then a doctor will do much more than a clinical officer can be able to do. We were looking at labor mobility and how we can be able to work outside, because we have trained quite many clinical officers that some of them are not actively engaged. And so we realized that we needed to move out and probably open up so that clinical officers can be able to work across Africa and beyond in other continents. But then we realized that we are having a problem in terms of nomenclature. First, we didn't know where they are, but we have been able to map, and now we know that we have clinical officers across around 87 countries across the continents. Oh, wow. Albeit with different titles. We are clinical officers in East Africa, clinical associates in South Africa. We are health officers in Ethiopia. We are community health officers in Sierra Leone. We are physician assistants in US. We are physician associates in UK. And basically, we have so many names across 33 titles, 33 different titles. And so what we are working on, and this August, we are actually in Birmingham, Aston. We are working at having a common nomenclature, having one title across the globe, so that then it can facilitate education and we can be able to go to different continents and countries and work there.
Wow. This is beautiful. I never knew this. This is like educating the audience, but also explaining what to do. So thank you very much. And before we continue, let's take a quick break. If you are enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube as well. So your support means a lot. Please like, leave a comment, share, and most importantly, drop a review. It helps others discover this important conversation and keep rural health conversation going. All right, back to the episode. You are still listening to What About Rural Health with Chinasa, and let's dive into the conversation with Mr. Peterson. So, Mr. Peterson, from a clinical perspective, what does rural healthcare really look like on ground in Kenya? And this is from the conditions of facilities to how field deployments are organized, especially in times of needs.
So in Kenya, we organize our health services in terms of levels. So we have a level one. Level one, we call it community level. And that is where now the prevention promotion happens. Then we have level two. Level two, we call it a dispensary. Usually you'll find a nurse. In the high volume, you'll find a clinical officer. Now there you have the prevention bit, the promotion, and then you have the basic primary curative for the basic conditions. Then you go to the health center, which is level three. Now most of them are headed by clinical officers. There you'll even find a maternity where they can deliver. Some of them have a theater and they have some bed capacity, usually about less than 50 beds.
Okay.
Then level four is the sub-county, or what we call the primary hospital. And now that will be a bit advanced. It will have different different specialties. You have medicine, you have surgery, and then you come now to level 5, and that is the referral hospital at the county level. But then at the national level, we have a level 6, which we call national referral health facilities, and they're also teaching hospitals. We have a few in Kenya, about 4 or 5. And now those ones, they have subspecialties and they're able to do subspecialized procedures. So now when you're talking about rural health, mostly it's at the primary health care. And in Kenya, the primary health care facilities are from the community health level, the community unit, or the level 1. We have the dispensary and the health centers. What usually happens there is more of prevention. So we have lay medics. That is, we call them community health promoters. These are people who have not gone to a medical school, but they are taken through a crash program of 3 to 6 months, and all they do is promotion and prevention. And that means that they are able to hold some barazas that would be bringing the communities together, giving health messages. They can be able to look at the environment, about the sanitation, and many other things around public health. And then they can report either to the public health officers or to the nearest hospitals. They help us to get disease outbreaks when they're starting, and also to prevent them in terms of sanitation. But they don't work independently. They have to be linked to a facility. They have to be linked to a public health officer. So then we have the dispensary. So if they are going to find somebody maybe has a risk for a certain condition, they are going to report to the nearest dispensary, so that now you can get a nurse or a clinic officer who can be able now to go to the community, or you can have the person coming to the facility, and they can be able now to do some investigations or examinations, depending on the condition, to ascertain whether actually the risk is there, the disease is there, and then they can also be able to reinforce the preventative messages. The same, they can also cure. If it's a mild illness like common cold and the others, they can be cured at the dispensary level. If they cannot be able to do that, then they are referred to the health center, where they can get now a more advanced clinical officer who can be able to send them to the lab. You have a laboratory technician who can now be able to take up the tests. Now, the challenge that we have is about the shortage of health workers, and we are unable to do what I can say is primary prevention in the right way. Because when you have a lay person trying to do the prevention, mostly they end up being scouts for those people with conditions. So they still feed into the curative, because prevention of a disease is a science. It is not something that lay people can be able to do. And so for you to be able to prevent disease, what we call primary prevention, because we have primary prevention and we have secondary prevention. Primary prevention is that person who does not have any disease, you prevent them from getting that disease in the first place. That is primary prevention. Secondary prevention, this person already has a disease, so you are preventing its progression or a complication. That is what we call secondary complication. So what we are doing in Kenya, and especially with the lay community health promoters, is what we call secondary prevention, because they are scouting for people already with conditions. So we get them early so that they don't get complications. But then for us to be able to guarantee people of their health, we need to do the primary prevention. And if you look at our data, what is really ailing our people and killing our people is non-communicable diseases, diabetes, the cardiometabolic diseases, the heart conditions, from blood pressure to heart attacks and so on. We also have the issue of rickets. We have the issue of road traffic accidents and what have you, some of which are related to some of the conditions. So for you to be able to do that primary prevention, you need a public health officer to be able to go to that village, test that water in the river or in the well where the women are fetching that water, ensure the sanitation is okay. You need to have a clinical officer and a nutritionist to visit the schools so that the clinical officer can be able to evaluate them, their nutritional status, and the nutritionist can be able to prescribe and can be able to sit with parents, because we have many cases of malnutrition, not that we don't have the requisite nutrients with us, but because we have knowledge gap. But then you cannot be able to impact if you cannot be able to explain to the population that your child is actually not doing well in school, your child is stunting, and it's because your meal plan does not support their nutrition, though you actually planned and you have whatever you require, it's only that you're not balancing it. We need the clinic officer to look at the child in that school and say that this child has risk of getting rickets, or they already have rickets, and then the nutritionist can be able to advise on what they need to do about that. And that is what I'm talking about, that we have not been able to get the qualified health workers into the community level to do prevention, while we actually know that every dollar you put into prevention, you save $9 that could have gone into curative. It is the best way to ensure that you have an affordable, effective health system. So the shortage is one of the biggest issues. The second thing is about affordability of healthcare. Like now we have a social health insurance, but every Kenyan has to pay something to be able to access. For you to be able to do that, and especially if you're not employed, for those who are employed like myself, you are deducted directly. And so you can be able to enjoy when that time comes, when it's working. Sometimes it's not working. But then for that farmer, for that miner out there, for that person who works who is a fisherman, then there is a tool. They call it means testing tool that you have to fill so that it can give you the amount for you to pay to join the social health insurance. Some of them, that tool gives some ridiculous figures, some of figures that may even be quite higher than even the employed staff like myself. And so it becomes unaffordable to them. And that is one of the greatest conversations that we are having currently in the country, that it is not actually working for the poor, because the social health insurance is actually supposed to work for the poor. Those with much pay more so that those with little can be able to access the same level of care that those with more can be able to access. But that objective has not been met by the model that we are having, probably because we discarded the model we used for so long, and we wanted to start a new one, and it is having some teething problems. So that's now coupled with the population. Our population is quite naive on health matters. And an example is this. Where I come from, we grow a lot of peas. You know peas?
Yes,
like
I do.
PEAS.
I do. I've been to Kenya.
Very nice. We have a lot of beans and very many protein-based plants. But then you'll find in my own area, people will sell those peas. They'll sell the beans and they'll buy carbohydrate like rice and bread.
Yeah.
And they believe that is a very good diet. They will feed their kids with that until they suffer kwashiako. Not that they don't have. They have it, but they don't have that knowledge. And you'll be surprised to even find out that some of them are people who have gone to school. So there is a lot that needs to be done in the communities to be able to educate them so that they can utilize what they have for their own benefit. Because the ripple effect of that is that if you have malnutrition, you have stunting. Stunting is not only of the body, it's also of the brain. So this child is not going to get anything in school.
Thank you so much, Mr. Peterson, for this elaborate explanation. And I can relate with everything that you have said, especially with farmers' attitude And I think most of these things is also part of the problem with socialization and become socially integrated, where people think, oh, eating rice is fancy and, rich men nutrition. Meanwhile, they plant very nutritious
Yeah.
meals like vegetables, beans, and etc. But they would rather sell it and then buy the rice to eat. So, they look rich and they appear rich. So there's a whole lot to be done there. And I appreciate that you took time to explain this in this episode. I will pivot a little bit to your work around infectious disease. I know that you were part of the Ebola response. I mean, that is where I saw you, and presumably that you are also part of the COVID response. But that's not where I'm going with this question. So I was reading a paper published last year by Jetari Farida and colleagues. And by the way, I am doing a research on public health coordination, in public health emergency coordination in Africa. So I stumbled upon this paper, and fortunately, you were going to be in my show, and I was like, I'm going to bring this question up. So what Jetari and co, the paper is titled Recent History of Disease Outbreak in Kenya, and they look at the Kenya health disease outbreak between 2007 to 2022, but the paper was published last year. What they did is analyze, the routine surveillance data, and what is showing is that depending on the county that you are in, Kenya experiences anywhere between 1 to 10 disease outbreaks in a single year. And to me, that's a staggering burden, especially for rural healthcare system that is already stretched, like you have already explained it elaborately prior now. So based on your experience, what has it been like working through these outbreaks? And, more importantly, what are some of the systemic challenges that you see when it comes to rural health emergency preparedness, but also the response in Kenya?
Yeah, thank you, Chinasa. And I think in Kenya, we have had several outbreaks. We have had an outbreak of COVID, which I think was a pandemic. We have also had an outbreak of cholera. Mm-hmm. And I think sometimes typhoid, but not that much. Cholera has been there quite severely. And then, of course, we have these, the flu outbreaks every now and then, but those ones are not that bad. So during the COVID outbreak, and I think it's out there, even in the social media and the YouTube and in the media, we really had a lot of issues in Kenya. Then comes COVID. Kenya was actually caught flat-footed. And that is the time now they were looking for the people who had responded to Ebola outbreak. And by the time we were having cases in Kenya, we didn't have mechanisms in place. We didn't have the protective gears. We didn't have the many things that we required. Though when the same started, we came together as health workers who had worked outside there. And we tried to advise the government, especially from the associations and the union side, that before we get COVID into the country, there are a few things that we need to do based on the experience we got in West Africa. And by the time it came into the country, we were caught flat-footed. Many clinical officers contracted COVID-19. A few health workers died from the same, very unfortunate. We even had to go on strike for the government to be able to procure some of these things and for them to be able to take it seriously.
Wow.
And for me, that was a very unfortunate scenario, being that it was a very great investment for a country to have sent people out. You are not only sent out to go there and probably deal with Ebola. When you send a contingent out, you are sending people to gain knowledge and experience to come back and help their own country.
Yes.
And so for us, we felt bad about it. But then, and that is why I'm saying that we have a problem. And the biggest problem we have in this country of ours is implementation of laws and policies. We have beautiful laws. We have beautiful policies. In fact, the universal health coverage being implemented in a country like Rwanda, the blueprint is Kenya. But Rwanda is doing it better than ourselves. because we have a problem in implementation of our own laws and policies. We make them, we share them, they gather dust, but most of the times we do not implement them. And so even after COVID, we have still found ourselves in some of the counties having people dying of cholera. You can imagine sometimes back, we have lost more than 100 people to cholera. Some of the traditional diseases that you wouldn't expect in a middle income country like Kenya to be killing people. So that is some of the things that we are advocating against. And that is why we go out there and ask the government, can you be more serious? Can you give more budget? So our biggest problem, I can say, is health financing. Because health financing determines everything else. It determines the number of staff we are going to have that can be able to respond. It also determines the capacity building in terms of training that you need to be doing from time to time, and even the purchase of the equipments that are required to be always there and ready waiting for the outbreak. So that has been the main challenge, and we are advocating to see that first we can be able to educate the policymakers. Politicians determine a lot, and sometimes they have little knowledge of these things. So you really have to educate them and persuade them to prioritize those things, and so that then we can be able to protect our people.
Thank you for this response. I really appreciate how you layered them down. We'll go for another short break, and then when we come back, we'll continue with Peterson Wachira. Do you have a rural story that you want us to share? Whether you're a health worker, you're a patient, a policymaker, or an advocate, we want to hear from you. Share your story on our website. Go to www.whataboutruralhealth.com/stories. Upload your story there. Someone will contact you regarding the modalities for how to publish them on our newsletters, website, and other media platforms. Welcome back. You are still listening to What About Rural Health with Chinasa, and with me in the studio is Peterson Wachira. So, Mr. Peterson,
yes,
I know you've talked a lot about the experience during Ebola, and when you were answering, I'm like, I do have a question to ask you regarding that. And
yes,
I also feel like we should spend a little bit of time to talk about the lessons that you have carried forward from those times and how you are now repurposing those lessons to advocate for change within healthcare systems preparedness in Kenya. And I know you've touched a little bit about that, but could also explain more. And particularly, what have you seen have shifted? Because everything is not only problems, what have shifted between then and now regarding your health systems? And then on one end as well, how powerful or resilient has it helped your team work with other frontline health workers to build a far more resilience within the rural healthcare systems?
Yeah, thank you, Chinasa. And I think the lessons from Ebola is that you should always be ready.
That is definitely the truth.
But now we have to break down, what does readiness mean?
Mm-hmm.
And that readiness means that you must have a department that looks at that does surveillance, continuous monitoring, which outbreak might we be having and where and when, and in future, which one do we expect? And that team, that is to be doing projections of future outbreaks, and then to also put in place mechanisms to ensure that the response will be immediate, will be robust, so that it can be contained before it, of course, goes to a wider population. Because if you look at Ebola, the reason as to why so many people died is because the West African countries, they were caught also flat-footed. The health workers were not enough. They didn't have the protective gear. The community, and the community is a very important aspect whenever you are doing the response. the community was not empowered in terms of knowledge, and most of them, they either looked at it politically, others looked at it religiously or spiritually, and some of them were thinking they were bewitched. Some of them thought that it's the government in power, and because they come from an opposition area, they want to be wiped out. So it took a lot of time to actually educate people and understand that actually what we have, it is something that only science can be able to help, and then we have to listen to the messages about how we are able to prevent it and protect ourselves in terms of behavior change and all the other things that surround that. So there are several aspects. There is of course, the surveillance. There is the communication bit. There is the clinical bit. And so those are the lessons that we took. And that's why I'm saying that when we came back to Kenya, we have always been advocating for that NPHI to be that department that now does that and ensures that we are always ready. And as I said, the problem is that it has not been fully operationalized. But then it's an advantage that we actually have one. And now it is working to the extent that it is able to do. And also, we have the community is empowered because, especially after COVID now, we even have 2 departments under the Ministry of Health. And we have 1 department under the Ministry of Health full with a principal secretary that deals with public health.
Okay.
And now there are people, there are community health assistants, there are public health officers who are attached, and you'll even find the PS in the villages conducting something they call in Kenya, ondoa uchafu. That is Swahili. In English, it would mean we are doing away with the dirt, direct translation.
Okay.
Sanitation, to mobilize communities around how can we make our sanitation better, how can we make our environment conducive and better so that we do not get illnesses from it. And that is a very good aspect of prevention and of infectious diseases, because infection prevention and control then requires that the communities themselves must be empowered to ensure that the environment is safe for themselves.
And I will attest to that. When I visited Kenya, I went to a lot of rural communities. I went into counties. I mean, there's a story to be told, but one thing that I noticed and I kept saying is that it doesn't really matter whether I was in the city or I was in the periphery. The one thing that I saw was cleanliness. The level of neatness that people operated in was really commendable. So I would definitely say that's like the high point for me visiting Kenya last 2 years. So Mr. Peterson, I want to pivot a little bit to talk about the workforce itself. One thing that I have always found that is powerful, honest, and very humbling is the resilience of front healthcare workers in rural areas. And I must commend their work because, the conditions at which they work are very deplorable, yet every day they dress up to show up. So what do you think keep them going, even when the system feels broken and resources are limited and the burden is heavy? What do you think fuels their commitment? And how can we better support it, not just in words, but in real structural ways?
True. And I think I can answer that using my personal experience, because in my early service years, I was working at some point at a dispensary, then for some years in the health center, and I really dealt with communities. And I can assure you that it was really resource limited. But what keeps you going is the impact you see. When those people who may not be able to afford a higher level of care, they come to you, you improvise because you don't have the equipment, and you can be able to assist them, and you know that I saved a life. You know that I prevented death somewhere. I prevented somebody from getting complications. That is what really drives us, because I don't think even the salary, the monetary gain is something that you can say is a driving force, because it is not that high. But the impact you see, the smile from that patient, the fulfillment you feel from a patient coming back and saying thank you. Some of them even bring chicken and farm products to just say thank you for what you do. That really gives us fulfillment, and you feel that you really impact the society and you're important to them, and then you feel that you must always be there, because without you, then it is going to be worse. So how can we be able to support them? How we can be able to support the health workforce that is working down there? Number one is ensuring that we have adequate numbers. According to the World Health Organization, if you are to see patients very well and give them a quality diagnosis and management, you need to spend at least 15 minutes with the patient. And if you are to spend around 15 minutes with a patient, within 8 hours, you can only see a maximum of maybe 35, given that you have to go for a health break and probably lunch. In Kenya, we have clinical officers in the community or the primary healthcare levels that actually see up to 100 patients. And sometimes we say some of it is weakness because it is not humanly possible.
Yeah.
But the reason as to why that happens is because we are supposed to be having around 24,000 clinical officers across our public health system, but we only have around 7,000. So it means every one clinical officer has to work for around 3-4 other clinical officers that are not employed in the health system.
Wow.
And if you don't see them, these patients, there is nobody else to see them. So sometimes you have to probably work harder, but then you suffer from burnout, fatigue. Sometimes you make medical errors. So it would be very important in terms of support if we can have adequate numbers of staff for both their mental health, so that we do not give the wrong diagnosis and get medical errors, not because they are not competent, but because they were seeing them when they were already fatigued. And of course, that would mean that we have enough budget. We have enough budget and financing so that we can be able to recruit them. But then even after you recruit them, you must ensure that you have equipped the facilities down there. Right now, we are saying that we should have the requisite diagnostics machines. We are evolving, and we have very innovative machines that are very portable, that can be able to do many tests, and they can be in the dispensaries, so that we get that quality diagnosis very early at the dispensary level, and so that the patients do not actually have to come to the higher facilities. If we can get that support, then I believe that we would have healthier societies. We will have wealthier societies, because there are so many people who spend a lot of their money, and because the social health also insurance only can serve to a certain level. And when you have to get the complications to go to private hospitals, sometimes you cannot access that because there are no equipment in the public health facilities. You spend a lot of money. And that is why in Kenya we say that at times you are only one sickness to take you into poverty. So if we can be able to do that, we'll be able to support the health at the community level, but even better, we will be able to support the communities to ensure that they have better health.
Thank you so much. One thing that I got out of this is improvisation is one technological innovation we often ignore when we discuss health workforce. And many health workers who work in rural communities do this every day. And there's a learning in that by using, minimal or limited or nothing to getting someone the health care they need. I mean, we can talk about quality as, in a different conversation, but at least getting people out of immediate danger. So for want of time, I want us to move into policy. What do you think in Kenya that the policymakers do not understand quite clearly, and how do we get them back to understanding the importance of prioritizing healthcare?
Thank you, Chinasa. And we have very good policies. I think if we could be able to export and get some foreign exchange for the policies and laws, Kenya would be very rich. Our biggest problem, we do not prioritize health, and so that means that we do not finance it. So what we can do, because that is the question, is what we are doing. And that is where some of us are out there, is doing advocacy. Advocacy in terms of making the communities know, because we have been talking to the policymakers, mostly headed by the politicians, because even our cabinet secretaries are political figures. The people in parliament who give this budget are politicians. We have been talking to them to a point that it has dawned on us that probably it is not that they don't know, it is that they don't want to. And probably because when they get sick, they have very nice covers, and most of them will actually not be treated in Kenya, they'll go overseas. So we have now decided to also take our advocacy to the constituents, the people who elect them, so that when he goes back home, when he's going on his tour or going on a campaign trail, then the population themselves can tell them that we want 1, 2, 3, 4 for our health. That is the language they understand, the language of the votes. If we want our votes, we want you to do 1, 2, 3, 4 to better our health care. And to some extent, it's working, because even the improvement in the social health insurance that we are getting, though sometimes it is failing in terms of the amount that people need to pay. But on the other hand, in terms of facilitating treatment, especially the surgical procedures and what have you, the cancer patients, the dialysis patients, it's really working well. And this is a product that has come from the communities themselves, because when this government was coming into power, we went out there. We mobilized communities. And when they were going around and asking people, what do you want us to do for you? It was very prominent that people were saying that the most of the expenses that we use as households is in seeking medical care. So sort health and you'll have sorted us. And that is how now this government has been able to some extent to prioritize even more than the previous government healthcare. And if we continue in that trajectory, I believe that in future we are going to be having one of the best health systems across Africa.
Thank you so much, Mr. Peterson. And just to recap all that I learned and I heard from you today, number one is investing in rural health is a matter of urgency. And Mr. Peterson, you made it clear that rural health system cannot be treated as an aftermath, like, from under-resourced clinics to overstretched staff. The gaps are systemic, and you've made that clear. And the solution must be systemic too. So government must really take action and prioritize health funding. And then the second thing that I hear from you is that at the heart of your vision is this powerful idea that frontline health workers are the backbone of any health systems, and they deserve more than applaud. They need protection, recognition, and policies that reflect their effort. From this, all of your experience, you're able to put this together and push for the upliftment of health workforce in Kenya. So I really appreciate you for doing that. Do you have any final words as we wrap up?
Yeah, thank you, Chinasa. I think my final words would be the communities, the citizens, they must be empowered enough, and we must go out there and empower them to own health. Many a times, I have seen communities looking at health as a product that is given by the health workers. And any time that they don't get a quality of the service that they want or they deserve, then they point their fingers at the health workers, not realizing that they actually hold the power. They are the one who actually hold the power to make the health better. And they are the ones who can actually be able to hold the people they have elected, who are in charge of the budgets, are in charge of the policies, to account and to direct them to where they want them to go in terms of bettering their health care. As the health advocates like yourself and myself and all the others across Africa and beyond, we need to go out there and educate communities to make them own health and know that actually they are the ones who hold the power to make it better. But I must also congratulate you and thank you for this very nice program and for the work you are doing to highlight and prioritize the issue of the rural health. Because once you get it right with the rural health, then you have sorted the communities.
Thank you so much, Mr. Wachira. Thank you so much for joining What About Rural Health and for sharing not just your expertise, but your lived experience from the front line. These are the kinds of insights we need more in shaping health policies and strengthening rural healthcare system. And to our listeners, thank you for tuning in. If today's conversation resonates with you, follow What About Rural Health. For more field-based stories, perspectives, and bold conversation from the people doing the work. Don't forget to subscribe, leave a review, and share this episode. Until next time, I'm still your host, Chinasa Imo. What about rural health? Let's answer this question together. Thank you and bye.